And that's probably the way our patients can get better quickly. Thank you.
Thanks, Binla, for these clear concepts on, I think we'll do the questions at the end of the session.
Our next speaker for today is Dr. Krishnaswamy Sundararajan. He is currently the director of the intensive care unit at the Royal Adelaide Hospital. He is a gold medalist during his fellowship in anesthesiology. He's the winner of the B. Braun International Scholarship for Scientific and Academic Excellence in Anesthesiology and has been awarded Masters of Public Health and Philosophy from the University of Adelaide. His areas of interest include health service research, qualitative research in patient and family support, medical emergency teams and tracheostomy outreach teams, as well as clinical teaching and medical informatics. He also has a special interest in cricket with a focus on India-Australia test matches. His topic for today is VA ECMO and ventricular assist devices in cardiogenic shock. Welcome, sir.
Okay, thank you for the kind introduction. And I'm really amazed as to how Binila and myself have both used the same opening slide, and I promise we didn't talk to each other. Okay, so, so just to show where I come from, most of you are aware of what Australia looks like. So I work in Adelaide, as you just heard, in South Australia. It's a large catchment area for Central Australia. So we do take patients from the Northern Territory and also from the bordering towns in New South Wales and in Victoria. So we would call ourselves a moderate volume center. We do about 20 to 25 cases of ECMO per year. But I would like to acknowledge that I'm no expert in ventricular assist devices because we don't do that in Adelaide. We do ECMO, but we seek assistance from Melbourne, particularly from the Alfred and St. Vincent's in Sydney, if we have a patient who needs to be supported with ventricular assist devices. So I would like to acknowledge that I have spoken to a couple of my colleagues who work in Melbourne and Sydney for this talk, and I'm grateful for their contribution. So I would like to take this topic on a philosophical note because it's a provocative topic. It's whether it's a pathway to recovery or is it a road to fertility. And I'm sure all of you would have read this poem by Robert Frost, The Road Not Taken. And the most important aspect of that is the final bit where he talks about the two roads diverging in the wood. And, we found that I took the one less traveled by, and that made all the difference. And we always wonder in medicine, okay, what if I'd taken the other option? What if I'd done this? And, again, as you just heard from Binila, we have different stages wherein we move towards a destination therapy, but sometimes we question ourselves. And again, I'm hoping that I should be able to give you an answer here. But at the same time, as long as the decision we take is in patient's best interest, I think we can go to sleep as a happy doctor. Now, the other question here is about recovery versus fertility. Okay, and again, the fertility aspect of it, I'm sure some of you would have read it before, but the word fertility comes from the Italian word frutilus, which means it's fruitless. But the importance of this picture there is from Greek mythology, when this is the 50 daughters of one of the kings was married to another king of 50 husbands, and all but one died. And what they were cursed was that they had to fill out this bottomless pit for the rest of their lives with water because it had a sieve in that, and they ended up filling water, and they could not complete that because obviously it is a bottomless pit, which means that everything was going waste. So this was a curse which they had. So sometimes we feel that in medicine, we keep doing things because we've already started on that. Okay, so we have done this transplant, we want to support them in ICU. We have done this surgery, we want them to be supported. We keep doing it, and then we realize that if we are far too down the lane and we have not decided whether to continue forwards or to stop. And then, we have this decision on whether we should stop now because it is futile. So it is again important for us to realize that we need to draw the line on the sand and say, look, time is up, we need to make a decision now. So moving on from the philosophical constraint, now to talking about a patient here. So this is a case vignette I would like to use. You have been asked to review a 35-year-old woman. She has presented with a shortness of breath with mild pleuritic chest pain and no past history of note. So this is a real story, by the way. So she was alert with a pulse rate of 122. Blood pressure is really relatively normal. Had a low-grade temperature, respiratory rate, as you can see. and again has got moderate muscle, accessory muscle use. Otherwise, relatively okay, lactate is on the higher end. So in terms of the differential diagnosis, you are going to have a wide range. Okay, so I won't go into the details of it, but suffice it to say that you're going to start thinking along the lines of cardiac failure first and foremost, whether this has got to do with myocarditis or acute mitral incompetence. And then you have the infectious complications, pneumonia and aspiration pneumonitis. And then you talk about whether this could be in setting of a pulmonary edema or an embolism, or could be just severe anemia. So this patient, in fact, had established shock. Okay, so one of the things which we need to be aware of is that you don't really need to be hypotensive to be in shock. You could be normotensive, but with disordered perfusion. So in this situation with the high lactate count, the patient being in shock was good enough for us to take over this patient. And then we soon realized that this patient had worsening myocarditis and needed to be supported. I've got a couple of slides here for the trainees, mainly because you need to understand, I see this quite often with my trainees as well, when they see a patient on the wards and they look, okay, the blood pressure is normal and everything, and they think, okay, the patient is not that critically unwell. But we have to realize that blood pressure does not equate cardiac output. Okay, so pressure is easy to measure, but flow is not. And that's why we are using pressure as a surrogate for flow. And we need to realize that, you could be in severe established shock, even with a normal blood pressure. And sometimes what happens is that when you see these patients on consults, on med calls, and we haven't really switched that thinking of yours on, you could actually make an erroneous decision. And again, just to go back to the physiology, because as critical care clinicians, we are essentially applied physiologists. Okay, we apply our physiology in clinical decision making, and it is important for us to understand as to why the oxygen consumption can be affected. Okay, and this could be affected by so many factors, as you can see here. And our role as as a physiologist in this situation is to address all these issues moving on. In the interest of time, I won't go into each element of it, but suffice to say that these are the elements we need to be cognizant of. I'm happy to share the slides as well. So, and again, moving on in terms of the next steps is the critical DO2, is the mismatch between the VO2 and the DO2. We are more worried about what happens with the critical DO2, the delivery of oxygen, and the extraction ratio. So these patients who are critically unwell with a shock state have a compromised extraction ratio, and that needs to be addressed fairly soon by organ supports. So coming back to this patient now, so this patient has had a cardiologist opinion, and as an echocardiogram report that has been generated for you, has got an ejection fraction of 20%. Okay, it's got a small pericardial effusion. Okay, so now you're going to start thinking along the lines of, okay, what's driving this in this particular patient? Okay, so you got myocarditis as one of the differentials here, and you have a wide range of differentials. You may want to add a few things differently in the Indian context, but I don't think that will be too different. But then there is an issue around drug toxicity and autoimmune pathology, and not to mention radiation as a consequence. Either way, over the course of the next few hours, she becomes unstable. She has an inherited requirement of noradrenaline, is oliguric now, and then you insert a PA catheter, and these are the numbers for you there. Okay, you got an occlusion pressure of 24, which is what you need to know, and then you've got an index sitting at 1.3. So this patient is really, really unwell, okay, and has got an ACO2 of 48%. Okay, so the possibilities here are that, okay, this cardiogenic edema, you got essentially a moderate pulmonary hypertension going along with it, or could this be in the setting of a vasoconstricted state from noradrenaline, and also the problem with mitral regurgitation. Okay, and again, with mitral regurgitation, you have to understand that your assessment of LV function is going to be different. If the ejection fraction is 20% with an MR in the context, the actual ejection fraction is going to be a lot less than that. So which means that you have to be really worried about how you're going to support this patient. So this is a vicious cycle, as you can see here. You start with an impaired cardiac output, and then subsequently have tissue hypoxemia, there is diminished vascular reactivity, there is hypoperfusion and end organ dysfunction. So this goes on and on and on. And what happens in ICU is that we are essentially circuit breakers. We need to do something here as an intervention to try and break this cycle, to use this to break the circuit of viciousness. So what therapeutic options we have in this patient? Okay, so first and foremost, obviously, you're going to take over the ventilatory requirements for the patient. They're going to be on mandatory ventilation. You're going to achieve biochemical homeostasis. You're going to optimize the fluid management. And then you start thinking about pharmacotherapy here. Okay, so again, the way to address that would be looking at afterload and preload. So with afterload reduction, certainly nitrates and ACE inhibitors and inotropes with inodilators. And then comes the mechanical circulatory devices, either IABP or ECMO, or your LVAD or your BiVAD, and then finally transplant. And again, a couple of things along the way is whether it's appropriate for you to consider antiarrhythmics and diuretics as well. So this patient is this is an AI-generated image, okay? And but again, the story was essentially that, she was a young lass with 2 children, and she did get home after being supported, not necessarily requiring ECMO at that time, but got better with conventional treatment for her myocarditis. Now, the question is, okay, where do we go here? Look, this patient, would she have needed ECMO? We would have offered it to her. The answer is yes, but she managed without requiring that. But on occasions, if they're not going to be responding to conventional treatment, would you consider them for ECMO? The answer is yes. VA ECMO, we would consider them for reversible pathologies. And also the other element is about ventricular assist devices, and we have quite a few here. And in terms of the ventricular assist device, and this is something which we have worked with Alfred about, is that in terms of medical management, we have a 61% relative risk reduction with just medication therapy. With cardiac resynchronization therapy, we get about 24 to 22% reduction. If you manage the arrhythmias better, we have a 35% relative risk reduction. And with the interventions, again, you have to choose the right patient, okay? So PCI or CABG, essentially for heart failure in that setting, doesn't have a mortality benefit as much as we can think of. What is the evidence for IABP in the situation? Again, in IABP, the issues are quite profound, and we have a wide range of evidence for that. But the overall practice of using IABPs in our practice has certainly come down in recent times. Okay, so we have moved away from using prophylactic IABP in patients who are requiring PCI. Okay, so there used to be a situation wherein we had patients with tight main or triple vessel disease. We used to put IABP prophylactically, but then we have realized that we are actually creating more harm than good. Okay, so I think the fundamental principles in medicine, primum non nocere. So firstly, do no harm. I think it is quite important. So we have gone away from that. So as a consequence, we don't put enough balloon pumps these days. The IABP Shock 2 trial, which was again a path-breaking trial, it's more than a decade since it came out. And again, in cardiogenic shock, did not show an improvement in 30-day mortality and no long-term benefit. Okay, and then there was a review which was published subsequent to that. Again, did not have any survival benefit. Okay, so does it mean that we should take IABP off our shelves and keep it in the museum? The answer to that is no, because you will have the occasional patient wherein you would need IABP support, and we would have to consider that, especially in the post-operative setting. So in relation to the other evidence along that, the meta-analysis around that as well, which showed that the relative risk reduction of 4% mortality is not particularly significant. And then again, there was a reduced risk of other complications, as you can see. And then overall, in terms of the other elements to it, sometimes you can consider that in association with VA ECMO. Sometimes you need the balloon pump to try and offload the left ventricle, especially if there is issues with what appears to be a hyperexpanded LV in the setting of poor contractility. You need that as an offloading device. Okay, so you may want to consider IABP support for someone on VA ECMO if they have ongoing pulmonary edema. And that's something that has been done in Australia. And certainly in our experience, having seen in centers like, the high volume centers in Paris, they do routinely put IABP along with VA ECMO as an unloading device. But otherwise, the use of VA ECMO is certainly coming down in that situation, purely in the post-cardiotomy space. And also that, when you put IABP along with ECMO, you have to be really worried about vascular complications. So you don't want to be in a situation wherein you've lost a limb, and then you go into the cycle of rhabdomyolysis and then worsening renal failure. And then, you think that you've won the battle, but you've lost the war, okay? So that's important. So in terms of the evidence behind VA ECMO, look, the evidence is widespread, okay? So if you look at it in the situation, certainly the systematic reviews and meta-analysis in cardiac arrest situation certainly showed that the increased survival and a favorable neurological outcome. So the question is that, you need to choose the right patient here. And the ECLS shock trial, and again, in patients with acute myocardial infarction who were complicated with cardiogenic shock, and there was a planned revascularization, the mortality 30 days was not lower to the ones where they were treated with medical treatment alone. So this study has influenced our practice quite a bit in relation to ECMO, certainly the ECLS shock trial, which did not show a mortality benefit. And again, as you can see, the confidence interval, even though narrow, is crossing 1, and the p-value was not significant. So, this has been a difficult study for us in terms of accepting the reality of it. and also in convincing our medical managers about the funding we need for a VA ECMO service in this space, especially in light of this negative study. And then the other bit is in relation to the patients who are deteriorating with cardiogenic shock and who have worsening hemodynamic profile, again, does not show a mortality benefit. But what it actually shows is that, I have not gone into the details of it, is that if you're considering ECMO, you need to start considering it before the end organ hypoperfusion starts to manifest. Okay, and again, goes back to what Binila said in the previous talk. If you're contemplating something, you start early, okay, and then you go hard first. Okay, you know, as I say, fail fast and learn fast. Okay, so if you are going to learn something, it is better that you get onto it fairly soon. You don't, start it very late in the process, because it becomes a self-fulfilling prophecy, because you're actually starting something which is going to be futile and it's not going to be in patient's best interest. So how do you know this patient is not going to benefit? So when we have spoken with the centers who are referral centers for VAD centers, say, for example, the Alfred or the St. Vincent's in Sydney, we would talk to them and they would always ask us for organ dysfunction scores. They would like to know what the lactate is like. If the lactate is sitting at more than 4 and the patient has got renal failure with cardiogenic shock, we would not put them on ECMO, because there is no destination. So it's either a destination therapy as a recovery, as a bridge to recovery, or as a bridge to transplant. Sometimes it's a bridge to decision making, because you haven't had the consensus opinion with the referring teams or with the family. The family expectations are outweighing what the patient's condition is. So you're putting this patient on ECMO essentially to give some time for the family to reconcile to the inevitable. But this is not the right indication. Okay, you don't put them on something because you can. You should be putting on something because you should. All right. And also the advantage sometimes is that you have the benefit of having these devices, but if we question ourselves whether this is the right thing to do, more often than not, we wouldn't be doing it. So where does LVAD come into place? Okay, when is LVAD considered? Okay, and again, that is as a transition to advanced heart failure. Okay, so when oral therapies have failed, and then you're considering essentially these patients for advanced heart support. Okay, so you would put them on LVAD, see how they go with compliance. So they need to go through multiple stages, so they need to be counseled first. They need to be demonstrating that they are compliant with medications. They have a supportive family to look after them. And then once they tick all the boxes, then they will be considered for transplant down the line. But there are multiple devices here, which is all available on the web. I won't go into the details of it, but how does it fare? Okay, so this is not in the context of infectious complications like myocarditis, but heart failure. So the 5-year survival is sitting at around 56%. And with the LVAD, in the quality of life, again, increases by about 91%, as they say. It increases other parameters as well, like, for example, the 6-minute walk test and also the NYHA grading. So if you compare head to head between medical therapy and if you're looking at LVAD, the median survival sits around 2 years for medical therapy only for advanced heart failure. And then for LVADs can go up to 5 years or more. All right. And again, the other bit is going to be, okay, there is a survival benefit. Okay, but is survival the only endpoint in ICU studies? Okay, so we have moved away from that in the last decade, is that we don't just look at survival, we look at the quality of life. Okay, and again, in the previous talk, we spoke about the ICER ratios, and we're looking at where we want it. Okay, and again, if you look at the cost effectiveness plan, you really want it to be in zone 2 or zone 2 or zone 3. But then the reality is, when you're supporting these devices and you're putting up this business case, they really want this intervention to be more effective and less costly than conventional, which is very difficult to achieve as well. But either way, I think there is a benefit there for heart failure patients with LVAD. And again, if you look at this slide here, the patients alive on medical therapy, as you can see, and there's about 47% there just purely on medical therapy. And then if you look at the ones on VAD, it's about 14%. Okay, so the benefit of going on VADs is profound in compared to that group just on medical management for heart failure. And the other terminology which is used for consideration of VAD is this called the intermax profiles. And again, they look at how this compares to their overall functional status, in terms of how they go about it. And again, this is outside the scope of this talk, but just to show that these are some of the terminologies that are used by the VAD centers in trying to assess someone's suitability for consideration of VAD. So just to put it all in a nutshell in terms of how things have evolved in the last decade, certainly, starting from 2001, when we found that there was a survival benefit with LVAD treatment compared to optimal medical therapy in patients who are not otherwise candidates for transplantation. And in 2017, again, it was considered non-invasive if you're looking at a survival-free issue outcome compared to the conventional treatment. And then the HeartMate 3, which is the one the last 5 years, certainly has shown to be a positive study with high survival. But again, I would like to reiterate, it all depends on case selection. Okay, so this is not for all comers. You have to be very careful with your case selection. You have to be absolutely sure that this patient is going to be compliant, and not make any assumptions. You have the team to go along with it, and only then you can achieve success. It's not a given that these patients are going to do well with VADs, because it is a resource-intensive undertaking. So in terms of the future for LVADs, look, we have to understand that volume outcome relationship. Okay, you have to cohort all those patients in one center. There's no point in 3 centers in a major city doing the same procedure. Okay, so certainly a state of our size in South Australia, we haven't landed yet on running VAD services because we just don't have enough patients for that. So we moved them to Victoria or New South Wales. Whereas for ECMO, certainly, we are doing more and more because, as I showed you in the map, we have a large catchment area. So perhaps that's something for Velo to think about as well. You want to make sure that you have the feeding units or the splinter units sending you patients so that you have the critical mass of patients to do this, because you don't want to venture into it, without enough patients in the first instance, and also enough support, both financially and in terms of the recurring cost to support that undertaking. So the future for the LVADs, look, due to technological progress we have achieved with the continuous flow pump, certainly the 1-year survival has exceeded 80%, and it is similar to cardiac transplant. So even if you don't proceed down the pathway of transplant, you can still support these patients with the VAD. There'll be still good outcome. The 5-year survival rate is about 47%, and again, transplant is about 74%. It is not too bad, and I think we tell your patients this is how it's going to look like. They might accept that. And again, now it's now destination therapy. It's not only survival, but also freedom from serious complications. So the evidence for ECMO and cardiogenic shock, I've covered some of this already in my previous slides, but just to suffice to say that the evidence at the moment is divided, especially we need to know as to what what the underlying causes. I might just focus my attention on Impeller. The organizers did not specifically ask me to talk about Impeller, but I thought it is pertinent to put this here because we're talking about cutting edge in medicine. And this is something that is going to change the landscape in the coming months. So it is good for the trainees and even for junior consultants to be aware of this, mainly because of this paper, the danger shock study, which showed a mortality benefit in patients with cardiogenic shock. Again, it showed a group mortality improvement from 58.5% in the standard care group to 48.5% in the Impeller group. And again, the Impeller, just for the uninitiated, is essentially a microaxial flow pump. Essentially it supports the LV loading and unloading and helps improve perfusion as a consequence of affecting the the way it improves the LV function. So it can be used as a bridge to recovery and again as a bridge to decision making as well. So I've got a 1-slide show of the danger shock study, which was a landmark paper. And what essentially they found in the study was that overall ECMO is not proven to improve outcomes in cardiogenic shock. But what they did with this study was that by using essentially in patients post-TEMI, that is within 36 hours, and those who present with cardiogenic shock within 24 hours and who have a lowest ejection fraction, they went on either Impeller or they went on standard care. And what they found was that there was a good separation. So the line in blue is standard care. The line in yellow is the microaxial flow pump. Okay, so as you can see here in the Kaplan-Meier curves, there's a good separation between the standard care and the microaxial flow pump. Okay, so what was the patient group? The case selection was those presenting with STEMI or equivalent, and again within 36 hours with cardiogenic shock, and essentially having evidence of hypoperfusion. So which was documented to be a lactate of more than 2.5, mixed venous of 55% or less, and having a systolic blood pressure of 100 or less, and having an ejection fraction of 45% or less. Okay, so that was the carefully selected patient population. Okay, and then they found that they had certainly an improved outcome in that group. The strengths were essentially that it was not done in too many centers, and it was done predominantly in Europe. As a consequence, they had good protocol compliance. And when you have good protocol compliance, certainly you can argue about the Hawthorne effect and also, the importance of, the single center studies or centers with minimal variation having better outcomes. And the limitations of that obviously is the external validity of that as well, which is what we are considering at the moment. So, and then do we have capacity to use it? We are in the process of starting Impella in our unit, but again, it comes with a different setup with regards to supporting the staff and others. But again, we're looking at doing it in post-MI setting, not in heart failure setting. Okay, so coming back to the topic, recovery or fertility, again, it depends on the case selection, the indication, and more importantly, as to what will determine the outcome. So what are the factors that will determine the outcome? So I've said about case selection multiple times, but I would like to focus on team concept. So what teams are doing at the moment is certainly going with the heart team and the shock team. Okay, so certainly from our experience in Australia and also some of the centers I visited in Germany and the US, they are moving towards having a heart team and a shock team. Okay, so what that means is that they have a dedicated intensivist, a dedicated cardiologist, and a dedicated surgeon in that group. Okay, so when a patient presents with that situation, essentially they are activated. It's like having a med team. Okay, and then you page the med team arrives. So what it has been shown is that the multidisciplinary team having corporate support improves outcomes. Okay, and also patient education and counseling goes along with that. So it's a team sport, and certainly the evidence for that is that there is improved outcomes from that. The mortality drops from over 23%, to 23% from 29% with such teams. And also in terms of the LVAD program, certainly it is important to understand that we can't do this alone. And this is again another meta-analysis which shows that the LVAD centers perform better having a shock team to support that initiative. But the issue here is in terms of unwarranted clinical practice variation. Okay, so we talk about all this, but then we have issues in terms of compliance with protocols and policies and guidelines, and we have changes happening as a result of that. So what it means is that we need to revise guidelines. So if you're looking at starting Impella in your unit or even an ECMO service, having a guideline which everybody conforms to it. So it's not just the unit guideline, it's an organization-wide guideline, which means that the cardiologists, the surgeons, the anesthetists, everyone has seen it and they say, okay, look, we are happy to support that. And that is important because we need to minimize the knowledge and the skills gap or the knowing and the doing gap. And I note in the conference schedule that we have a session on implementation science separately as well in terms of how we translate research into practice. I think it is also important for us to understand that, research, lags behind, what happens in clinical service delivery, so that we need to actually learn from what we are doing, and the knowing-doing gap is important. So we need to minimize that. So I might just focus on some of the things as to what has been the greatest risk for receiving healthcare. And, this is just to show that, there is the 60-30 challenge. Okay, so what that essentially means is that whatever we are doing in medicine, 60% of the care is in line with evidence or consensus-based guidelines, okay? And 30% of the times we do something which is what we call as waste, or non-beneficial care or low-value care. And 10% of what we do is actually harm, okay? And, when I put this up for discussion with my team, they're all shocked to see this because they think, okay, whatever we're doing, everything is for benefit. The reality is we have to be humble and we have to understand that despite the fact that we're thinking we're doing the right thing, we can only achieve success in about 60%. The 30%, the gray zone can either be beneficial or non-beneficial. And the 10% is going to be frankly harm. And, that is, something we need to be careful about. And we need to realize that, we have chosen the right patient for that. And if you don't choose the right patient, we can actually cause them more harm than the problems they actually came up with. So to summarize, okay, just to go back to the initial topic, which was given to me, in terms of ECMO and VAD support, there are three broad categories here: heart failure, arrhythmias, and infectious like myocarditis, endocarditis. As long as we choose the right patient for them, the VAD support especially is going to be secondary to heart failure, it is still beneficial. Okay, so I would consider that as a road to recovery. Okay, if it is an infectious problem, if it is myocarditis, an inflammatory problem, yes, certainly yes, you can consider that because it is reversible, again, as a road to recovery. Very procedural support for arrhythmias. I haven't gone into the evidence for that in the shortness of time, but more importantly, VA ECMO can be considered for that group. It is beneficial. But post-iototomy or post-cardiotomy cardiogenic shock, especially if the patient is having multivalvular disease, having a complex surgery in theater and they're going to put this patient on a centralized VA ECMO, the answer to that is it's going to be temporizing measure, but the outcomes are not going to be particularly fantastic. What essentially they're doing is that they're just transferring a patient from a bypass machine to an ECMO circuit. Okay, I would call that as an extension of the bypass surgery. It's an extension of CP bypass. So the outcomes in that group, at least in our unit, is not great. Okay, but in that group, wherein subsequently, if they've taken the approach of not doing surgery but doing it as a PCI, and if they develop cardiogenic shock, then Impella is showing promise there. And if Impella shows promise and it continues to show promise, I'm afraid it's going to put cardiac surgeons out of their jobs. I think peri-procedural, specialties certainly has dented, the influence of cardiac surgery, but Impella can do that in the years to come as well. And again, post-iototomy via ECMO, the outcomes is dismal. And I haven't specifically spoken about eCPR because ECMO CPR, I think it's a separate kettle of fish. I think that needs to be handled, separately. But the bottom line again for eCPR is that single center studies have shown promise, but in the larger scheme of things, the outcome is still very poor. Okay, so I don't think we have enough evidence to recommend eCPR as a standard of care. So coming back to the road less taken, look, the fork on the road situation is not something which is uncommon. We face it all the time. But more importantly, I think if we put our patients right in front and center and decide as to what's beneficial for that patient in front of you, because there is a big separation between what trials have come up with and what happens in real life, I think you will make the right decision. Okay, and I think the case selection goes wrong, or if you're doing something because someone has told you, or you're doing it because you want to satisfy the surgeon or you want to satisfy the referring teams, then more often than not, we'll make the wrong decision. Thank you.